Thank you for the presentation. Good evening, everyone. It's such a pleasure for me to present our research project to you today. At Gemelli Hospital in Rome, where I work at, the management of individuals with CMT may fall under different teams because pediatric patients are followed by child and neuropsychiatrists. Instead, adults can be followed by neurologists or by our team of physiatrists. So last year, keeping our vision and mission in mind, we have decided to direct our attention to the plantar fascia and to the cavus foot for several reasons. First of all, because the cavus foot is the clinical hallmark of the disease, because both cavus foot and plantar fascia can have a direct impact on gait and balance, because an examination of the plantar fascia has never been conducted in this population, and lastly, because the plantar fascia may prove to be a target for early and conservative treatments, considering the fact that therapeutic genetic treatments are ongoing. We enrolled in 2024 26 patients who attended our CMT ambulatory and who were able to perform gait and balance tests. There were 12 males and 14 females with a mean age of 49, and the most frequent genetic type was, of course, 1A. Everyone was assessed with clinical tests. Of course, we have used one specific for disease, CMT examination scale, and different scales for the functional evaluation. We have used the Detenetti assessment scale, which is a performance-based test, which evaluates balance and gait. Lower scores are indicative of poorer balance. SPPB, which stands for Short Physical Performance Battery, instead evaluates lower limbs function, and lower scores are indicative of worse physical performance. Walk 12 questionnaire is a self-reported measure which evaluates the perceived impact of neuropathy on the walking ability, and 60 is the maximum and indicates a severe limitation. Then we have used the 10-meter walking test, which measures the walking of speed and asking the patients to walk at a self-selected pace. Then an ultrasound evaluation of the plantar fascia of both feet was conducted, and all patients were assessed in the prone position, and given the typical foot deformities, the foot was maintained in a neutral or slightly dorsiflexion position to tension the fascia and optimize its visualization. The parameters collected were the thickness, measured in millimeters, at the point where the plantar fascia is thinnest near the calcaneus. A normal plantar fascia has a thickness of 2-4 millimeters. Then we have collected the presence-absence of inflammation signs at the power Doppler, and in the absence of validated classification combining echogenicity and fibrillar structure, we have proposed a three-category. We have qualitatively described these characteristics, and so we have proposed a three-category grading system based on them. And so we have found a type 1 with a no hypoechogenicity and a preserved fibrillar structure, and type 2 and type 3 with hypoechogenicity and a severely disrupted fibrillar structure. Our results revealed a no increase of plantar fascia thickness, the absence of inflammation signs at the power Doppler, and the presence of ultrasound pattern, alteration at the ultrasound pattern, specifying, however, that half of the subjects presented type 1 with normal aspect of the plantar fascia. Other results revealed significant differences between age and ultrasound pattern, with the most significant one between type 1 and type 3, and significant differences between CMTS values and the ultrasound patterns, with a significant a difference near to the significance between type 1 and type 2. And then significant association between ultrasound patterns and functional assessments, such as 10-meter walking test and SPPB. So these findings suggest that the alterations found at the ultrasound assessment of the plantar fascia reflect a chronic disease process more than an acute inflammation status. That more reflecting and maybe reflecting alteration of the foot, the biomechanical alteration of the foot, and by the changes in gait characteristics. More severe plantar fascia ultrasound alteration are common in older patients and in more severe clinical and functional impairment, most of all in subjects who had lower speed and lower physical performance. We are aware of the fact that our results must be seen and evaluated with the study's limitation, but they give us valuable insights. First of all, that plantar fascia alterations, like I said, reflect chronic degeneration, more evident with increasing age, disease progression, and functional decline. That ultrasound is a non-invasive diagnostic tool, so useful for early evaluation and for monitoring these patients due to the chronic nature of the disease. And lastly, that plantar fascia should be a target for early and conservative intervention. I want to thank you, the group I work with, and thank you for the attention.
Thank you very much for this interesting study. I'm not sure if I missed it, but did you look at non-CMT controls and whether changes occur with aging, similar to what you see in the CMT patients?
There is not a control group, neither CMT patients, neither healthy subjects, just because it's an exploratory study, and also because the evaluation of the plantar fascia and the ultrasound examination of the plantar fascia has not been conducted. So we have decided to just describe this type of target.
Yeah, but it would be interesting to know if it's a normal aging process. Okay, any further questions?
I can ask you a question. In what ways could these findings be used, or how can they be applied?
For the clinical for the clinical aspect and also for the therapeutic one, because we want to apply a control group with an intervention target, for example, with shoes insert, orthopedic shoes or other ortheses, and compare the aspect before and after this type of intervention.